Clinical discourse and patient assumptions often default to the missed menstrual cycle as the official initiation of pregnancy. Biological reality suggests a different timeline. Days before any expected menstruation, a silent, microscopic event occurs deep within the reproductive tract. While remaining undetectable from the outside, the maternal body begins a process of massive physiological reengineering. We will trace the exact endocrinological shifts, starting from a single cellular event, to map how microscopic signals generate macroscopic changes. Understanding this specific timeline allows for the precise differentiation of standard reproductive cycles from the onset of embryonic development. By the time a period is missed, the complex biological mechanism of gestation has already been operating at full capacity for several days. The biological timeline begins at the moment of post-ovulation fertilization. For the first 6 to 10 days following this event, the embryo remains free-floating, triggering no systemic symptoms in the mother. This simulation shows the critical milestone of uterine implantation. Here, the blastocyst physically anchors and embeds into the highly textured vascular wall of the endometrium. This mechanical attachment involves specialized cells burrowing into the endometrial lining to secure a permanent hold. Physical attachment establishes the first functional communication bridge between the embryo and the maternal bloodstream. At this stage, the embryo is roughly the size of a pinpoint, yet it must now command a maternal organism millions of times its mass. The mechanical question is how this localized microscopic anchor alerts the entire physiological system to halt the menstrual cycle. Implantation serves as the definitive biological spark, transitioning the body from a localized cellular event to a systemic state of gestation. The moment physical contact is secured, the blastocyst begins synthesizing a specific chemical messenger. This molecule is human chorionic gonadotropin, or HCG. The embryo synthesizes HCG, releasing it into the maternal capillary network. This signals the body to arrest menstrual shedding, while sustaining the corpus luteum to ensure hormonal production for early embryonic survival. The exponential accumulation of HCG in the blood and urine serves as the primary biological marker targeted by clinical pregnancy diagnostics. HCG acts as a master endocrinological switch, forcing the adjustment of systemic hormones throughout the body. Its rapid entry into the bloodstream is the biological telegram that reprograms the female reproductive timeline. This primary signal triggers a secondary multi-system hormonal cascade. Rising HCG forces a rapid elevation of systemic progesterone, inducing smooth muscle relaxation, gastrointestinal bloating, and profound fatigue. Concurrent estrogen fluctuations modify neurological receptor activity, increasing mood variability. Simultaneously, the vascular system adapts, rapidly increasing maternal blood volume to support the placenta. This sudden expansion induces mild dizziness and forces increased renal filtration, leading to frequent urination. Neurological shifts heighten olfactory sensitivity and acute food aversions. These symptoms provide the first external evidence of a total body vascular, metabolic, and hormonal reprogramming sequence. Because these systemic symptoms occur just before an expected period, patients frequently misclassify them as PMS. Both the late luteal phase of PMS and early embryogenesis are driven by overlapping fluctuations in progesterone and estrogen. Differential diagnosis requires parsing subtle divergences in physiological markers. Menstrual shedding involves heavy volume and complete tissue breakdown, whereas implantation bleeding is light spotting. Menstrual cramping involves expulsive contractions. In contrast, implantation produces mild pulling sensations as the uterine wall structurally modifies. While fatigue can occur in both, the unique presence of sudden olfactory and gastric nausea strongly indicates the gestation pathway. However, physiological responses vary significantly. A completely asymptomatic early gestation stage remains clinically normal. Early self-diagnosis relies on distinguishing a uterine muscular contraction from a structural modification. We now shift from internal mechanisms to actionable clinical protocols for patient care. Proactive care begins with disciplined, systematic symptom tracking rather than immediate reactionary assumptions. Clinical testing should be delayed according to this timeline to allow sufficient HCG to accumulate in the urine for accurate immunoassay detection. Upon suspected implantation, immediate behavioral modifications are required, including the cessation of alcohol and the avoidance of unsafe medications. patients should immediately initiate folic acid supplementation to support early neural tube development. Absolute clinical red flags include severe acute pelvic pain, heavy hemorrhage, or recurrent franking. The presence of these red flags requires immediate physician intervention to rule out ectopic complications. Adhering to clinical timelines and disciplined tracking prevents diagnostic errors and establishes a baseline for maternal health. A single microscopic cellular anchoring event triggers a vast interconnected systemic cascade that prepares the body for pregnancy. These initial physical shifts represent an exquisitely orchestrated immunological, vascular, and metabolic adjustment required to sustain new life. Achieving physiological fluency regarding this timeline empowers patients to move toward proactive medical decision-making. Interpreting these initial biological signals correctly ensures the optimal physiological environment during the fragile primary weeks of gestation. Understanding the mechanics of one's own body dictates the entire trajectory of early maternal care.